Hello, everybody. Welcome to the Interventional Psychiatry Consortium, a global hub for interventional psychiatry education and community. We are so excited to have you all here today for our inaugural Circuit Club. This is our new Journal Club series. Just another one additional part of our educational programming, bringing important topics in interventional psychiatry to learners of all stripes. Today will be a little bit different in format from our typical sessions. This is discussion-based, and we encourage any degree of participation that you feel comfortable. So, as you might notice, your cameras and your mics are all enabled, and so please feel free to turn on your camera. There'll be points during the discussion where you can unmute yourself and chime in. And hopefully this could be a lively discussion between learners and experts alike. So in terms of our broader programming, I just want to highlight a few things. We show this calendar every single time. We have 3 general sessions left in the year, and we just added one for May 7th. So in April, we're going to be hearing from Sherab Trangala at Yale University, who will be speaking about interventional psychiatry in special populations. And May 7th, we have a new talk that we are unrolling on the FDA approval of home use occipital and trigeminal afferent stimulation for depression, given the recent FDA approval of Neuralif ProLive RX. We are going to have Linda Carpenter and Andrew Luchter, who are both involved in the clinical trials, as well as Owen Muir, who is involved with the company that created this technology. They're going to be coming, speaking to us about the evidence for the technology and its applications. You do not want to miss it. Now on to our speakers. We are so honored to have, for our inaugural Circuit Club, speaking with us, 1 trainee and 1 faculty, who are both founders of the consortium. So I'll start with Simran, or Simran Ailani. She's an academic chief resident at Maimonides Health. And excitingly, she'll be joining Yale for the Interventional Psychiatry Fellowship next academic year, and we'll be following along closely. She'll be leading the discussion along with Jeff Zabinski, who is the Director of Interventional Psychiatry at Columbia, as well as Associate Program Director of the Columbia Adult General Psychiatry Residency, and I'm lucky to be in that program with him, and so honored that you are here to lead the discussion. So I'll hand it off to you, Simi.
Thank you, Yaakov, for your kind words, as always. Let me share my screen, and then we can begin. Let's see. Okay. Me and tech don't get along very well, so I need confirmation. Is this working? Yes? Okay. Okay. Jeff, the floor is yours.
All right. Well, let's go ahead and get started. Yeah. So, we are hoping that this will be a little bit more informal, and that you all can kind of turn on the cameras and that sort of thing. Today, for our inaugural journal club, we're going to be talking about the ELEKT ECT versus ketamine for non-psychotic treatment-resistant depression randomized non-inferiority trial, and kind of just breaking this down a little bit, understanding the study design and kind of just walking you through it. And so Simi and I were really excited to kind of present this because it overlaps in several of the interventions, and I think has a lot of lessons for the literature more broadly. Oh yeah, no disclosures. Okay, so a few learning objectives. We're going to look through a case of treatment-resistant depression that's sort of a composite case that of some folks that I've seen in our clinic. And then we're going to talk through, like I said, the design rationale for non-inferiority trials. We're going to look through their methodology in some detail, and then interpret the primary and secondary outcomes, key limitations, and then we'll kind of circle back to these findings in a clinical decision-making, kind of from that standpoint. Maybe we could revisit the case and if there's anything that we would do differently. Okay, So here's the case. So this is somebody who the person is primarily based on somebody who I saw over the course of about 2.5 years. So a 39-year-old woman with major depressive disorder, as well as ulcerative colitis. There's a number of other comorbidities, but this is the one that is most relevant, I think, for our discussion. Who presented to the clinic for ECT versus ketamine. This was specifically the referral from the primary psychiatrist. We offer interventional treatments beyond that, but this one was really kind of targeted. So the patient has had a persistent depressive baseline ever since the first episode of depression, which happened in college. The earlier episodes didn't last quite as long. It's more like 4 to 6 weeks. Although as time has gone on, the episodes have lasted longer, a 6-month episode. And then the current one at the time of initial evaluation was about 8 months. Symptoms had been worsening. I think the primary psychiatrist was also wondering, is this somebody who's headed towards an inpatient admission, or is this somebody who can stay outpatient? The medications that she had tried were helpful in early episodes, but it's really only partial response in the past 10 years. And there have also been some worsening with the ulcerative colitis, just not really great control, an increased number of flares, and the patient really links the flares to the depressive episodes. It's not a one-to-one, but it was something that she was really kind of focused on. No history of mania, psychosis, substance use disorder, suicide attempts. So as far as a little bit more psychiatric history, so major depressive disorder, recurrent severe without psychosis was really the primary diagnosis. And then we had some hint, there had been a previous diagnosis of obsessive compulsive disorder, but really kind of teasing it apart was more like obsessive compulsive traits, more in the realm of personality than it was an obsessive compulsive disorder more classically, and wasn't particularly relevant to the presentation at the initial evaluation. She'd been on multiple SSRIs, SNRIs, TCAs, had been on nortriptyline, amitriptyline, lithium, lamotrigine, notably hadn't been on an MAOI. And then had gotten ECT about 10 years ago with clear benefit. So it was 10 treatments with ECT over the course of a few weeks during an inpatient admission. But when asked about this, the patient was really saying, I had really terrible memory deficits afterwards. And to this day, I continue to have this fogginess. It's just my thinking isn't as crisp and as clear as it was before I had ECT. So kind of coming in with a little bit of I really don't want to have to do ECT again based on that experience. Multiple trials of psychotherapy as well, CBT, ACT, psychoanalysis. In fact, in the, I think, year or so prior to coming in for this evaluation, had been doing analysis about 4 days a week. And that physician was also her psychopharmacologist, was also doing the medications. So in any given episode, really characterized by poor self-care, low motivation, low energy. So some pretty significant neurovegetative symptoms, wanting to sleep constantly and not being able to sleep. Appetite was impacted by the ulcerative colitis, so kind of screening for appetite changes related to depression was more challenging. And then difficulty concentrating, didn't enjoy hobbies, ceramics, other activities. And was pretty tearful while describing the symptoms, saying that most people, like at work, so this patient was still working, said, people don't really know how really severe this is. I try to hold it in. Said that she felt like a failure despite many accomplishments. Well, it's my assessment that she had many accomplishments, but she said she felt like a failure. No seasonal variation, no diurnal variation in symptoms. Okay, and then just a little bit further with the social history, because I always like to have a bit more context. You should, when I have try to get social history for interventional evaluation, I try to get a pretty long social history, really chronologically. But this particular patient grew up in New York, positive relationships with family, came from a high achieving family, as well as was high achieving herself, did very well in school, graduated from college, graduate school. Although the first episode of depression had a substantial impact on professional ambitions. It was right before taking a standardized test that sort of would have helped determine some next steps. Did terribly on the test as a result of being in the midst of the most severe episode that she had to date, really one of the earliest episodes of depression. I can't remember if it was the very first one that impacted that test, but it kind of sent the patient on a little bit of a different trajectory, or at least that was the patient's perception. And then single, no children, lives alone, but has good support from family and friends, talks about other family members. They see each other, I think, at least weekly, and does cognitively demanding work. And then the two medical conditions I just wanted to highlight, or rather one medical condition and one piece of history. So ulcerative colitis. So patient is treated by gastroenterology with regular follow-up and intermittent flares with prednisone. So regular kind of dosing of prednisone along the way, and wasn't in a flare at the time of evaluation. And so just to say, the patient was experiencing depressive symptoms independent of the ulcerative colitis at least at this point in time. And then a seizure history. So had 2 seizures within 24 hours of starting bupropion. I felt like this is one of those things, is like a test question, but sure enough, it had been 20 years prior to the initial presentation. No recurrence after discontinuing the medication, followed up with neurology for a little bit of time afterwards, and was on seizure prophylaxis, but no longer. Subsequently had normal EEGs. If you remember from the timeline, 20 years ago, so 10 years later, had ECT, and kind of a little bit more history with the seizures was discussed then. And then at this point, it sort of was far in the rearview mirror, although I did touch base with the neurologist, who had no concerns if we had been considering TMS, which really wasn't on the table for this patient because of logistics and really patient preference.
Sorry, Jeff. I think you covered this, but you said she's had done ECT before. Did she try ketamine before too?
She's not tried ketamine before.
Okay.
So this is the first time she's considering ketamine or Spravato. I don't think she really knew much about the intranasal S-ketamine when she was coming to this evaluation. And so it was part of the education. I mean, we talked through TMS also, but I think some preferences became clear pretty quickly, that she would consider ECT if it was the #1 recommendation, and she would consider ketamine, but really she kind of leaned towards ketamine before our discussion was more complete. Okay, so I thought we maybe would stop here, and if there are other questions, so like that question, pieces of history or other things you might want to know when thinking about this patient who now is let's say, felt to be appropriate for going forward with a treatment. She's tried lots of medications, really interested in ketamine or ECT if we recommend it. What would you, is there anything else you might want to know? Or do you care that she had such a good response to ECT before? Does it make you think, yeah, maybe we should lean that direction, or?
Hello. I'm just wondering that in her case with the prior cognitive adverse effects with the ECT, like what is the patient's overall, like how does she feel about ECT and doing it again? Like, was it a very big issue for her in the first place? Is she still fearful of getting it done again? So just probably understanding what is her current perspective on doing ECT again would be helpful to know.
Mm-hmm. Yeah, so she said that that the cognitive effects really bothered her, and there was a sense that she attributed the ECT, or the sort of cognition, the fogginess that she was experiencing, to the ECT, even though I think other people, including when I got collateral from her primary psychiatrist, said, yeah, I actually think that this might be related to the depressive episode, and that she really just hasn't been as sharp since becoming more severe over the last 6 to 8 months. And so it's certainly more patient perception than it is, although we didn't have neuropsychological testing. So we don't know if there were significant, other significant deficits that could have been there. But she's performing really well at work, sometimes struggling to keep up with workload during the busiest times of year. But yeah, she's pretty fearful of the potential for cognitive effects again, but she's still open to ECT because it was so helpful. I see. What kind of ECT did she receive? Unilateral, 10 treatments, didn't switch to bilateral. Was a pretty quick responder.
I have a question. I really appreciated Snape's perspective on, thinking about the patient's perspective going into treatment and attitudes and expectations. Different interventional clinics are set up differently. I'm assuming this case is somewhat inspired by the way that Columbia is set up, in which he has a lot of people come to it and think it's a ketamine clinic, and are really there for a specific modality. Did she come in hoping for ketamine in specific, or this was a broader interventional consultation?
Was a broader interventional consultation, and she was open to medication management as well. She just said, I'm feeling bad and I want to get better. It was kind of like that. She said, if you recommended that I try an MAOI, my psychiatrist has been encouraging me to try an MAOI for years. And so I'm open to that, but I really just want to know what you would suggest. And so at that time, we had the availability of outpatient and inpatient ECT, IV ketamine, Spravato, TMS. So, she really did have a pretty wide range of things that she could consider, and that we talked through. So one piece of information that I wanted before making much of a decision was to talk to her psychiatrist. And so I did have that collateral. Super helpful, really talented psychopharmacologist and psychotherapist, and was really able to kind of confirm the diagnoses and other medication trials, doses, etc. Had some really good medication trials. In a few instances had some response. But it really just hadn't been as good in the recent episodes. Yeah. Okay, so here's what happened. We ultimately decided to start with esketamine. She liked that it was a little less invasive and that she could stay outpatient. Oh, I should tell you about this graph. This is kind of a random graph. This is just me in Excel trying to show the patient what the progress looked like over time. So it's just QID scores, and then the number below is either a visit number or a treatment number. So this doesn't really represent time very well, because for esketamine, for example, it's twice a week for 4 weeks and then once a week for 4 weeks. So that's how you can think about this as instances where we got the QID. So the quick inventory of depressive symptoms, SR is self-report and 16 item. And so pretty good response with the esketamine. And then it was sustained to some degree, had some medication trials, and one of those medication trials included Parnate, and then ultimately just not really responding, and then elected to go to ECT and had a similarly robust response to ECT. And then after this graph, but no longer getting QIDs in the system where I could view them, she maintained that benefit. I had a visit with the patient about a year after the ECT course had largely completed. I mean, she did a brief taper, and she was still doing well, working, and actually had gotten the ulcerative colitis under better control as well. So this is a case where the patient had both esketamine and ECT. And I think, we talked about ketamine versus esketamine, but I think linking us in and kind of setting us up to think about, is there a right answer for what we should do first? Is ECT always better? Yeah, how seriously should we take patient preferences? I'll hand it over to Sim for the next part.
Thank you, Jeff. Just a quick question. So your last question here was, does the ulcerative colitis affect treatment choice? Does it?
Okay, so this is me being CL trained and making sure everybody's
Yes.
thinking through their medical like diagnoses appropriately. So ulcerative colitis, this patient did link the two, and the ulcerative colitis wasn't as well managed as it was when she eventually became more consistently in remission. So perhaps that might change the way we understand her depression, but it didn't really meaningfully shape the treatment choice in this case.
Gotcha. Makes sense. Okay, y'all. So we're going to be talking about the ELEKT trial now. This was an open label randomized trial and a non-inferiority one, and we're going to go into that in a minute. The treatment population was TRD, treatment-resistant depression, without psychotic features, though. They needed a baseline score of more than 20 on the MADRS, which is a clinician-administered depression scale. A score of above 20 correlates to moderate to severe depressions. So they're taking a pretty sick population. To meet the criteria of treatment resistance, they would have had to fail at least 2 adequate antidepressant trials. And then lastly, the trial was conducted in 5 centers and went on from 2017 to 2022. And please feel free to interrupt me and ask questions. We love that. So yeah. Okay, going through the treatment protocol, the first part is just the acute phase that lasted for 3 weeks. So on the left, you can see ketamine, which was given twice a week for 3 weeks. So 6 sessions in total at a dose of 0.5 mg per kg IV, which pretty much replicates real world practice, the acute phase of it as well. For ECT, it was given 3 times a week for 3 weeks. So a total of 9 sessions. Now we know in the real world, sessions can be anywhere between 9 to 12. So slightly, maybe a little bit lower than what real world practice is like. The dose was right unilateral ultra brief pulse at 6 times the seizure threshold, and you can switch to bilateral if an inadequate response is seen. And in this study specifically, they saw at about a median of visit 4, around 40% patients switched from unilateral to bilateral. So that's kind of important to note as well. Now going up into the follow-up phase, only the people who responded in the first 3 weeks went on to the follow-up phase. But this was naturalistic treatment, so basically do whatever you want. Patients received care as prescribed by their own clinicians, continuing ECT or ketamine, switching, or just a whole other treatment. So when we look at relapse rates, which we will a few slides down, we need to understand that it's more observational and not directly reflective of what treatment modality was assigned at the beginning of the study. Any questions about this? Okay. Baseline characteristics. So the groups are pretty well balanced. A few key points to highlight. The median age was about 46 years, about half were female, and 88% were white. And about 89% were outpatients at randomization. Now, we want to focus on the, let's start with the red boxes. So the depression severity. If you look at the bottom, the MADRS score, the median was 32, which if you know the MADRS rating, that correlates to the higher end of moderate depression. Severe depression starts at 34. So again, a pretty sick population. QIDS was at 17, you're already in the severe depression range. Jeff, I can hear you thinking. Do you have any thoughts about this?
Yeah, well, I know when we were preparing this, we talked a little bit about selection of rating scale. And so
Yeah.
I wonder if you all have thought much about this, or, you know, in clinic, when I have a patient who has, let's say, more moderate depression on the QIDS, sometimes I'll get another rating scale because I'll think, you know, this patient has a lot of symptoms that are sort of outside of the things that the QIDS measures. And, you know, like, I feel like we're missing something about the severity. My clinical assessment is that this is a severe depression, but this questionnaire is saying otherwise. I also just, you know, sort of outside of this in the real world, if you're giving a self-report scale to someone, I've had a few patients who have responded to it just sort of, I guess all of it is subjective, but just like hardly reading the questions where they'll be like, I have such terrible depression. They just give you a max rating on every single question. And that's not like something is lost in that also, or like putting 0. We have a couple patients who feel really great now that they're treated and they're in remission. So they have like a score of a 0. It's like, okay, well, maybe. But so I think that anytime there's a study, like understanding a little bit about why they might have chosen a particular scale, or, if it's consistent with the rest of the literature. Really commonly in the intranasal esketamine studies, for example, they use the quids in a lot of those studies. But what if there was a study that randomly used some scale you'd never heard of? So it's not like a red flag, maybe a yellow flag, but you just want to ask, well, why did they choose that one? And so it's kind of nice that they have scores from 2 different scales. And if both of them are pointing us sort of in similar directions, that's helpful to know.
Yeah, because the MADRS is clinician administered and QIDS is self-reports. At least we have that difference there. Yeah. Okay. Any comments? No? Okay. And then the median duration of the current depressive episode was 2 years, and about 40% of the patients had a prior suicide attempt. So again, a very high risk population. Okay, now looking at the patient flow, there were 403 patients that were randomized, about 200 to ketamine and 200 to ECT, but 41 withdrew before receiving treatment, of which 31 were from ECT and the others, a very small number, 4 from ketamine. So I'm not surprised, I'm not shocked, but this differential dropout reflects, number one, something that Sneh alluded to earlier, patient preferences, which is a very important thing to think about. And the other is logistic challenges that Jeff spoke about with ECT, anesthesia, transport, doing the thrice a week treatments, all of those things. And I think patient preference is so important that the writers of the study had a second analysis that they published, which spoke about this. And the results are pretty interesting. Patients who preferred ketamine had better outcomes regardless of which treatment they actually received. And preference matching, which means if they said they wanted ketamine and they got ketamine, that's preference matching, improved response rates specifically for ketamine. It didn't improve response rates for ECT, but there were lower reported adverse effects for ECT. And I think that's still a wonderful finding for a modality where there's a lot of anxiety about cognitive outcomes with ECT, right? So if patients at least feel like they aren't reporting as much of side effects with ECT, that's great. Any thoughts about this?
This was something I was thinking about when I was reading the paper too. I was imagining, because they took these people off a wait list for ECT, right? And so they came to a group of these people and said, hey, you don't need to go through this procedure. We have this hot new thing, this alternative. This was before the FDA approval. This was 2017 to, well, up until 2022, so in the middle. And the fact that regardless of the group, if they preferred ketamine, they did better. That does influence the findings a little bit, right? Because ECT improves people regardless of whether they want it, and ketamine, people see improvement when they want it. So I just think this plays a significant role in interpreting this study.
Oh, absolutely.
What also stood out to me was the intention to treat analysis here, or you notice that like they're saying that, yeah, I think yes, you already highlighted that down there.
Yeah, we're gonna go. We're here at intention to treat. What did you want to say though? I want to hear. We can jump
Well, just
around.
that like our intention to treat included all those people who then didn't, it's like undergo the ECT treatment, right? And so then that is right. So if you're including those people, it's going to artificially deflate kind of response with ECT. So I'm curious, kind of to looking at both the I appreciate the modified intention to treat analysis where they excluded that, where they excluded people who withdrew for those reasons.
Yeah. The primary analysis was modified intention to treat, which was at least some kind of a saving grace. But yeah, absolutely. Okay. Let's see. So now looking at the primary result. So on the left, your panel A is essentially what they were looking for. There's a response rate on the quids of 55.4% for ketamine and 41.2 for ECT. So there was a difference of 14.2 percentage points. And the 95% confidence interval was 3.9 to 24.2, which is entirely above zero. And the p-value was less than 0.001 for non-inferiority. We're going to talk about other things in a minute. Now, panel B showed the MADRS response, which was similar in direction, but the confidence interval just crossed zero, so it's not statistically significant. Okay, let's see. Very quickly, panel C and D kind of showed how the depression severity changed over the 3-week treatment period. So the x-axis is showing standardized assessment time points, and the y-axis is showing depression severity as least squares mean score. Now, I didn't know what this meant. There's a lot of new things that I learned and I had to look up and understand. Does anyone want to try to explain their idea of least squares mean? I would say nothing if it was me before doing the research. Okay. So instead of doing a regular average, like a simple average of all the scores, these are adjusted averages that would account for repeated measurements within patients over time, and it would handle missing data. So instead of just adding 4 numbers and getting an average, it accounts for people either switching or missing out. So it's more accurate, is what I'll say. Both treatments led to steady reduction in depression severity. The ketamine group showed slightly lower scores across most time points, which indicates somewhat greater improvement throughout treatment. Now, time to geek out a little bit more. So understanding non-inferiority design. A non-inferiority trial is asking a different question than a superiority one. We're not asking if ketamine is better than ECT. We're asking if ketamine is not unacceptably worse. So the investigators chose a margin, a non-inferiority margin of minus 10 percentage points, which means what? Ketamine's response rate could be up to 10% lower than ECT, and it would still be considered non-inferior. So if you look at this figure, can you all see my mouse or no? Yes? Oh, great. Okay.
Yes.
Great. There are 2 key reference lines, right? The line at 0 represents no difference between the treatments. So if the confidence intervals, like scenario C and D, if it crosses that, if it crosses 0, we can't even say one treatment is better than the other. The second line is the non-inferiority margin, which is a little bit more liberal. If the confidence interval crosses this, then we conclude the treatment is not unacceptably worse. So what do I mean? Just look at scenario B here. The entire confidence interval, as long as it's above this line, it's before this line, it's not inferior. And then you have the best case scenario, which is scenario A, where the entire confidence interval is to the left of both 0 and the margin of minus 10%. Does that make sense? Yes? Okay. So ELEKT's results actually looked like scenario A. Like we discussed, the confidence interval completely crossed 0, but we still can't say that ketamine is superior to ECT because of that, because the trial was not powered for it. The trial was determined to just look for non-inferiority. But it's a good thing to know that numerically the results were so good it was superior. Okay, now how do we read these results? There are 2 ways to do it. One, we just discussed, the 95% confidence interval. The second, this was the other thing that I had to look up and learn, the Farrington-Manning statistic score. It's basically asking the same question. Is ketamine not worse than ECT by more than 10 percentage points? The answer is given through a Z-score. And this is just good to know in general, because for non-inferiority trials, apparently this testing is done a lot. The minute you cross 1.96, you've established non-inferiority. You go to 2.5 to 3, there's strong evidence. In this study, we're at 4.64, so there's very robust evidence. Just 2 other things to know. The one-sided alpha was 0.025, and the power was 80%. I'm not going to go in details unless anyone has questions about why the alpha is not 0.05. Okay, now to Jarrod's point. So I'm sure you've seen the term modified intention to treat throughout the paper. Let's kind of break that down and understand what that means and why it matters specifically for non-inferiority trials. So broadly, if you see on the top right, this box, patients in intention to treat are analyzed in the group that they were initially assigned to, regardless if they switched or dropped out later. Versus per protocol, which is kind of more stringent, where only those who completed their assigned treatment are analyzed. Now, ELEKT did something else. It kind of found a midway point. It used a modified intention to treat analysis. This means they included all patients who received at least one treatment and had one post-baseline assessment, which came out to be about 91% of the patients. Now, why does this matter for a non-inferiority trial? Does anyone have any ideas? What would be the effect of doing an intention to treat for non-inferiority? It would dilute treatment differences, right? So if you do intention to treat, you're thinking if someone midway during the study switched from ketamine to ECT, somebody dropped out, it doesn't account for any of those differences. So the results on both groups turn out to be more and more similar and kind of become easily more equal. So it's easier to prove non-inferiority in an intention to treat analysis or a modified one. If you were trying to prove superiority, it would be the other way around. Does that make sense? Yeah, okay. But the authors addressed this concern directly with sensitivity analysis. They filled in the missing data using statistical models, and they got nearly identical results. So that's really important, right? Fine, they did ITT, but they tried to confirm the data by doing different kinds of sensitivity analysis. And this is what was really not cool, great. Even the worst case scenario, all ketamine dropouts are non-responders and all ECT dropouts are responders. Even if we assumed that, even then, ketamine was found to be non-inferior to ECT. So that's kind of in support of what they're doing. Okay. Jarrod, was there anything else you wanted to cover in intention to treat? No?
That was good.
Okay. Looking at secondary outcomes. So first, let's look at the red box here on the top. Remission rates measured at the end of the 3-week acute phase. QIDS remission was 32% for ketamine versus 20% for ECT. MADRS was 38 versus 22. Both statistically significant and clinically meaningful differences. Oh, and this is what remission was defined as. QIDS, it was a score of less than 5, and MADRS, a score of less than 10. However, when we looked at the follow-up data, I think this was interesting. ECT-associated memory decline did recover over time. So if you just follow this, you start at 37.4 as their baseline before treatment. Then it goes down to 28.7 at the end of treatment and starting to go back up. Month 1, 34.5. Month 3, you're at 40.6. You've crossed the baseline level. And then month 6, you're at 43.1. So again, it kind of goes back to that conversation of ECT's association with cognition and kind of the stigma around it and, you know, how it's harder for us to counsel patients sometimes for ECT because of this. Any thoughts, any questions? Okay. Very quickly, looking at overall safety, there were no deaths during the trial. The only statistically significant difference was this one, was the musculoskeletal side effects, more common in ECT, 5.3% versus ketamine, 0.5. And then dissociative symptoms were measured using the CADS, and they were consistently higher in the ketamine group throughout treatment, but they were transient and they resolved after each infusion. Okay. Treatment emergent SI. So there was one safety signal that I kind of wanted to talk about. During the acute treatment phase, new SI was reported in 4 patients in the ketamine group and 2 in the ECT group. The difference was not statistically significant, and during follow-up, there was 1 suicide attempt in the ketamine group. Also, just kind of to remind everyone, the maintenance treatment after the initial 3-week phase was not standardized. It was naturalistic, right? So we can't really account whatever happened after those 3 weeks directly to what treatment they received. And then I went on a deep dive, which we're not going to discuss a lot, but just very briefly, I kind of wanted to look at the relation of suicidal ideation and suicide attempts with both modalities and where we are at now in terms of literature. So just looking at SI, ketamine, as we would predict, is known to achieve about more than 50% SI reduction at 24 hours, and the effects last for about a week. And Jeff and I were talking about this. He said he's seen this clinically, where now we're seeing that the anti-suicidal effect is partially independent of the antidepressant effect. And the way it was shown in the study was that the MADRS score still stayed high, but the BSSI, the suicidal ideation scores, went down. So that's kind of something to think about. And then with ECT, you did have reduction in SI, but it was slower, but the effects were also more sustained. With suicide attempts, it's the other way around. Kind of with ketamine, there isn't a lot of data out there for suicidal attempts or deaths, for it helping suicidal attempts or deaths. And then with ECT, pretty strong data, 50% reduction in suicide deaths and reduction in all-cause mortality. For anyone who's been working with these treatments, does this sound like the real world? Does this sound like what you've been seeing? I see Yaakov nodding. One person agrees. Good. Okay.
Well, I
And then
think you
treatment
represented my experience when you were talking about that before, but it was really surprising to me that there were patients who would come in for treatment and their scores the same time after time. And I remember having a conversation with somebody saying, well, maybe we might start to think about other alternatives. And they said, but I'm so much better. And I'm like, oh, are you? The symptoms were still really substantial, but the difference that was made was in the suicidal ideation. So I have had a number of patients who have continued treatment in more of like a maintenance phase or as a taper, who have just had improvements to the suicidal ideation, and it's been quite a relief. And it even seemed to be suicidal ideation beyond just major depressive disorder with suicidal ideation, that there were other sort of potential kind of etiologies of the suicidal ideation. I mean, even in the course of personality disorder or bipolar disorder, bipolar depression. And yeah, it's been a sort of practice surprise that's borne out in the literature, but it's interesting to see it.
Yeah, absolutely. I don't think this parallel makes any sense, but a while back I kind of asked somebody, what is kind of the evidence of clinical practice for using TMS in patients with personality disorders who have depressive symptoms? And the answer was, well, if it's depressive symptoms, we're still going to be able to treat it irrespective of the overall broad diagnosis. This kind of feels similar, where if they have suicidality, even though the depression might not be treated, this specific treatment of ketamine is helpful for suicidality. So yeah, absolutely. Okay. And then just looking at follow-up, depression scores increased during the 6-month follow-up for both groups. By month 6, about 35% of ketamine patients and 56% of ECT patients had relapsed. But the follow-up was again naturalistic, so these aren't controlled comparisons. Yeah. Okay. So I'm sure we all have thoughts on limitations of the study. This is what I was thinking of. Number one is ECT technique. A lot of people initially said, well, so many people switched to bilateral. Maybe if everyone started with bilateral, the efficacy might have been higher. However, we've spoken about this offline, a lot of us in different settings, that there is enough data to say right unilateral at 6 times the seizure threshold is just as good as bilateral. So I don't know what everyone's thoughts are on this.
My main concern with the ECT protocol was just the number of sessions. And it's a similar concern with ketamine. We all have seen patients who don't respond until well beyond, what was it, 9 that they did?
Yeah.
And sometimes right unilateral could just take longer. That's my main concern there.
Great. Absolutely. Yeah, the 9 sessions, because for ketamine, at least, that is kind of the acute phase many times, but for ECT, 12 is usually the number you go to. At least that's what I've heard. So, okay. And then the efficacy of ECT, right? Then here it came up to be 40%. Most of the data has usually been around 60 to 80. So what was going on? Why was the efficacy much lower? And does this kind of correlate to the conversations we've been having more broadly? Is the population just becoming more treatment resistant? Are we expecting all future papers to be like this, where the efficacy is only 40% or 50%, and that's as good as it gets? So, third, the open label design, like we said, patients' expectations. We discussed this in the beginning. It might influence the outcomes. Population, this was non-psychotic patients only. I think the beauty of ECT, which I don't know if any other treatment does that, is the sicker they are, the better it works. This is something a mentor told me a few years ago. So this is treating a non-psychotic depressed population. So that's also biasing the results in a way. And like we said, follow-up was naturalistic. There was no maintenance comparison. Anything else in limitations? No. Okay, so these are just our take-home points from the study. Ketamine is non-inferior to ECT for non-psychotic TRD, but numerically superior. Ketamine has less acute cognitive impairment, but ECT effects are transient, so it does bounce back. And then ECT remains preferred for psychotic depression, for catatonia, suicidality, acute suicidality, older adults. And then this is the point that Jeff and I kept coming back to the more we discussed this. Just shared decision making will guide treatment selection. There is no one rule for what works for everyone. And then these are a few discussion points. Does anyone have any thoughts, any questions, anything you want to respond to from this list?
I have kind of a little bit of a separate question. I became particularly fixated on that one slide about the secondary analysis, showing that like patients' preference, predicting outcomes, that ketamine was preferred and had like a lower dropout. How much of the observed non-inferiority of ketamine might be driven by like expectancy and like selection effects rather than like true biological efficacy? Like, is there like this, does patients' fear of ECT could actually worsen reported outcomes, like independent of like a true biological effect? And also this like whole idea that like ketamine it's very new, it's a very hot thing. You take the subway anywhere in New York City and you see signs all over for ketamine. I don't know. But I think an interesting point, I think, to bring up.
I have thoughts, but Jeff, do you want to go first?
No, it just, what my actual reaction is that always bad? I mean, like in real life, if a patient has an expectation that something is more likely to work and then it works, like that seems good. I think sometimes that's not appreciably different than like placebo effect is maybe the sort of psychotherapy effect of things too. And I think that, even if you're really open about that with patients, you could say, if you do this or like think about it in this way, or you kind of like build up a little bit of a different sort of transference related to the treatment, and if there's a real biological change that happens as a result of that expectation, then that's part of the treatment. When you're doing a study like this, yes, I mean, like it works in both directions, like a negative perception leading to maybe worse outcomes. So how can we correct that? What's our role in being advocates and managing stigma? Whenever I have an initial evaluation with a patient, I'm talking through ECT, and a patient, especially for a patient that might have like a like visible reaction, like, oh no, I don't want that. I say, well, keep this in mind. This is one of the oldest and most effective treatments in psychiatry. And we know that for some people, it's the right fit. And that might not be you right now, but it might be later. And so I think just filing this information away, just having that in mind for if you did need it, there is something that can be there. And sort of just setting up this, like, maybe right now there's that perception, but you at least introduce this so that you can try to, I don't know, mitigate some of that. And what that means for when we're trying to do studies and how you kind of cut that out of it and all of the, like, what are the details of those that might be an interesting thing to explore in more depth. Like, what are those perceptions? And are there sub areas of depression that might be more amenable to the impact of the perception? I don't know.
Yaakov, you were gonna say something. You're like
Well,
mid-smile. What's
yeah, just like conceptually in clinical practice, you want to leverage placebo effect, but in trials, you want to mitigate them, or at the very least, quantify them. Getting at your question, Casey, I do wonder in that second publication you put up there, Simi, did they quantify the expectancy bias, if that's the appropriate term? Because I'd be curious, because then maybe it does cross the line and pulls it out of non-inferiority.
Yeah, I don't think they did. I'll have to go back and look,
Okay.
but I don't think they did. Yeah. I think, Casey, to your point, like, number one, yes, if it works, it works. Number two, I think the perception is that biologically we don't know what's going on with ketamine, but that's not. I feel like there's a lot of data coming out now trying to correlate how psychedelics work, even from a biologic sense. Like, they're really trying to understand. There was one talk I think last year at APA. Jeff, you and I attended it briefly about how psychedelics affect you and they were showing like MRI images of how it kind of correlates in a biologic sense. So I think there's more coming out. We just need to be cautious. We just need to get all the data in and then kind of make a decision. We're not saying go to a random clinic in Midtown and they only offer ketamine for you're unhappy, you're sad. We're saying get all the information and then make an informed decision like you would for any other treatment.
But if you only offered a treatment to someone if they thought that it worked, like you have to, well, do you think this is going to work? Okay, you do think that, okay, we're going to do, I don't know. I was thinking about as we're talking, like, what are some of the like boundary conditions with these concepts and what would it mean if we tested them? I mean, I think that's how I feel with some of these, some of the trials too. It's like, what if it only works if you really like build up the like, let's say it's like if you build up a placebo sort of, the potential for a placebo effect plus the biological effect, and that together it's much greater than it is for one treatment versus the other treatment that you did exactly the same thing. Like, how would we know that? I don't know. I've always been stuck on these ideas because of the huge amount of variability that you see with patients coming into clinic. And the differences in the explanations, and it becomes so clear that there's a difference in understanding, based on all kinds of factors, social, cultural factors, and education, and what their occupation is. And,
Yeah. Thank you.
Yeah,
Any other?
these are all great points. Thank you so much.
Of course. Oh, sorry. 1 second. Yep.
I think your last point, something I think stood out to me, which is the question about kind of how preservation of benefit. Because the problem with, right now, I don't know if you guys have seen that toxicity ketamine paper from October 2025 in the American Journal of Psychiatry. They basically said that the FDA recommends no more than 8 lifetime ketamine infusions, given current safety data. And so, if that is the case, right, if that's the maximum we should be doing, then how do you keep people well? So I think often, at least in the S-ketamine context, we know if you stop the medication, people are likely to lose benefit. And in contrast, there was a study, I was pulling it up again, Navarro et al. 2008, which said that if people kind of get better with ECT and take nortriptyline over 2 years, 92% of those patients stayed in remission with ongoing maintenance ECT and concurrent oral medication. So, I think about ECT and esketamine and oral meds and stuff is something that can have a long-term tail to kind of keep people well. Even if the treatment is equally efficacious after 3 weeks, if you don't have a plan to keep people who get ketamine well, how valuable is that short-term benefit? And that's, I think, often what makes me most pause about referring or thinking about IV ketamine is not having a long-term plan the way we do for ECT or esketamine. So I'm curious those people's thoughts.
Yeah, I know when first thinking about, well, both esketamine and IV ketamine, I thought, okay, am I going to use this the way someone might use benzodiazepines in the treatment of anxiety, where you would start more of a long-term anxiety medication, but they're so distressed at this, right now, let's do a low dose of clonazepam or something. It's like, am I going to use it that way, where I start an antidepressant at the same time that I would start a series of infusions or a series with esketamine, so that when you finished, you had something else that could be more long-term or more prophylactic, as opposed to just having to repeat and repeat, with the short acting. And, I think in practice that hasn't really been the way that it's used. And, I think especially for patients who are really profoundly treatment resistant, who nothing else has ever worked. And, it seems like you're really doing a risk-benefit calculation that, I think becomes really hard. And it's tough too if somebody is saying, okay, well, I will continue this, an off-label treatment that has worked when nothing else has. I'll continue this, but I am not willing to go inpatient. I'm not able to do ECT at all. Like, would you then say, okay, well, then we need to what? Like, do you just discontinue and say, okay, well, unfortunately, given the current safety data and so forth, that we really just have to discontinue, and try something else. I mean, I think it puts you in a really hard spot. Do you see patients like that?
I mean, I think to kind of be somewhat conservative in our clinic, we have a ketamine-assisted psychotherapy clinic and IV ketamine in addition to our outpatient esketamine clinic. We do kind of abide by those FDA limits and say, hey, if we do either IM or IV ketamine, we kind of cap you at 8 treatments at our clinic. And, if we want to have a longitudinal follow-up, you can do something like esketamine, which has, now both naturalistic and clinical trial data out to 5 years, suggesting safety and efficacy and somewhat durability. Like we can do a tail with esketamine, but we don't kind of give ongoing indefinite racemic ketamine in any form. And as they kind of comment in that toxicity paper from earlier in 2025, it's like there's maybe some concern that racemic ketamine itself may be more toxic in animal models than esketamine. So we don't necessarily, the safety data we have from esketamine, we can't necessarily extrapolate that to racemic. But that's not what most clinics do. Something like 80% of ketamine clinics give ongoing treatments in some form. And so, I think that's often something that like to that paper's point, is something that to kind of to reflect on.
Yeah. I think for me to summarize, just I was thinking of question number 3, like what am I gonna do after this journal club? Does this change the way I kind of decide which treatment to recommend to patients? And I think it clarifies things a little bit more, not necessarily change, but the only thing I could think of was severity. Like if someone has, say, acute SI, but you know is doesn't urgently need treatment for whatever reason, you can offer ketamine as an option. If there's somebody who's high functioning, like Jeff, for your case, the first question I asked you was, does she have a high functioning job? Can she take time off? If, let's say, for ECT, sometimes the recommendation is you need that day and the following day off, like, just in case if because of the anesthesia effect. So those are the things that I would consider while recommending one treatment over the other. I don't know if there's anything else that kind of specifically stood out from this paper that any of you would take back and be like, I'm going to consider this now while counseling patients. Yeah. Okay. Okay. If we have no last questions, we can end for today. Please sign up here to know about future sessions like this. Thank you all for such an engaging discussion.